Kristen here at UT Southwestern. Thank you for joining us today. Today we're going to be talking about endoscopic ear surgery or minimally invasive ear surgery with otolaryngologist Brandon Isaacson. So we should have a really good discussion. I'm excited about this. Don't forget to like and share the conversation as we go along so that other people can follow along as well, and ask your questions in the comments field. We think we have kind of the little static issue resolved, but if you have trouble hearing it, try refreshing your browser, and that should help. But in the meantime, we're going to get started. Thanks again for joining us. Thank you for talking to us, Dr. Isaacson.
It's a pleasure to be here. Thank you for letting me be a part of this.
Absolutely. So we're talking about endoscopic ear surgery today, or minimally invasive. And I was wondering, just to start us off, what are some of the common kind of conditions that this would be used for?
So we use this often to repair tympanic membrane perforations, which is a hole in the eardrum.
Okay.
There's another condition called cholesteatoma, which is a skin cyst that develops in your ear.
Okay.
Rarely a child can be born with it, and it grows over time.
Okay.
But a lot of times it's acquired, which means that you develop from recurrent ear infections, you develop kind of a vacuum effect behind your eardrum, which collapses in.
Okay.
And the wax that comes out of your ear is not wax; it's dead skin mixed with sweat-gland material. And so, if that collects in the cholesteatoma or in the area of drum that's collapsed in, it gets infected and it causes the skin cyst to grow. So that's called a cholesteatoma. It's not a tumor, but it can act like one because it can destroy bone and cause problems with hearing loss, and dizziness, occasionally facial weakness, or serious problems like infection to the brain, which again is rare. And so a lot of times, before we used to have to make a fairly large, or not a large incision, but an incision behind the ear in order to access the ear to get address these problems. And sometimes we're able to do them through the ear canal, but it's a little bit more challenging to work through the ear canal because it's a narrow space, obviously, and it's not a straight line. It actually has a kind of an S shape to it, and so working through the ear canal with a microscope is not always that easy.
Okay.
So the endoscope, the advantage of it is that you get a lot brighter view. There's a lot more light because the light's at the end of the endoscope. This is an example of the endoscope. It looks something like this. This is a slightly bigger than what we use in the operating room.
It looks kind of like a flashlight?
Kind of, yeah. So this is where the light source, the light cord goes in here and attaches to a light box.
Okay.
And then there's a camera that attaches to this part, and it's got a whole bunch of small fiber optic cables in the scope.
Okay.
And then the light comes out of the tip of the scope, and same thing with the picture. And we look on a screen. It's projected on a screen, which can be very large, and you can see everything extremely magnified. And you can do the same thing with the microscope, which is what we traditionally use. But the advantage of this is that, again, you can get lots of light into the operative field, and then you can magnify just by moving the scope a little bit closer in and out of the ear, basically.
Okay.
So it allows us to see a lot better, have a brighter field of view. It allows us also to look around corners, which in cholesteatomas is a really key part of the treatment is the ear has lots of little spaces and nooks and crannies that you need to see, and it's difficult to see that with the microscope sometimes because you can't really look around a corner in these little nooks.
Right.
And so this provides a very wide field of view that you can look around corners and see disease that you weren't really easily able to see before without removing a lot more bone, basically.
Wow. And so just to clarify, we're one of the few centers in the country that does the endoscopic procedures, right?
Correct. I mean, it's becoming more popular lately, and there's more training available with different courses around the country. We offer a resident course every year, and we're going to offer a CME course next year in 2018 for people who are already out in practice. But as far as academic medical centers, we're definitely one of the few in the country that do this. And it's not just me as part of the team. We have Dr. Coots, who has been on earlier, and Dr. Hunter, who was on a few weeks before him. And then we have two pediatric providers who also do endoscopic ear surgery, and Dr. Gopi Shaw and Ken Lee.
Wow, you have a big team.
Yes.
All right, so as we're getting along, let's talk about the prop you bought today. Now, this is obviously the ear. This is the ear.
It's obviously a larger than life model, but basically you have your external ear. You have your eardrum, which is kind of right here, basically. And then you can see there are little ear bones called the malleus incus and stapes, which connect the eardrum to the inner ear. This is going to fall apart probably at some point. And so the way we do our surgery with an endoscope is we actually go through the ear canal, and you can see everything, including the eardrum. And if there's a hole in the eardrum, you can see through the eardrum.
Wow.
In order to do cholesteatoma surgery, you have to make little incisions on the canal skin, and you elevate the eardrum up off the that's covering the middle ear, and then you can look and deal with things like cholesteatoma or problems with the ear bones. You can actually replace these ear bones, which are really small.
Wow.
And with prosthetic ear bones, or you can even use those ear bones and carve them and put them back in. And so the endoscope just goes down the ear canal, basically, as you can imagine here. This is a little bit bigger than what we typically use. It's a little wider. This is 4 millimeters in diameter. The one we typically use in the OR is about 3 millimeters in diameter, and it's a little shorter than this one.
Okay.
We've also been one of the few centers in the U.S., actually there's only one other center that's done in the U.S., where we've actually removed tumors called an acoustic neuroma. The acoustic neuroma, actually, which we talked about a few weeks ago with Dr. Coots, comes off the hearing and balance nerve here, the 8th cranial nerve, and most commonly it comes off the vestibular portion of the 8th cranial nerve, which is the nerve that controls your balance. And so we can actually remove those tumors through the ear canal, basically, without making an incision behind the ear.
Okay.
Doing traditional ear surgery, we typically make an incision right behind the ear here that starts typically somewhere right up here, and then it goes around the ear like this, and we have to lift the ear forward.
Gotcha. So that was one of the questions, how what you're doing with endoscopic or minimally invasive differs from.
Right. So you have to transpose the ear forward, which, you know, the patients end up with a little swelling after the surgery, and their ears kind of sticks out for a little while, and usually that goes down after a few weeks to a few months. And we think that doing traditional ear surgery would be more painful than endoscopic surgery, but we really don't know that for sure. So we are actually involved in a study here at UT Southwestern looking at both pediatric, or both kids and adults as a separate population, and comparing outcomes of open ear surgery with endoscopic ear surgery. And so we're looking at using a pain survey to kind of determine is it really less painful or not.
Okay.
Because there's not that, right now that data is not really out there.
Gotcha. We've got a question. This one came in from Georgia. So Georgia says, hi, Dr. Isaacson. How do you get a hole in your eardrum?
So that's there are a number of reasons. Most of the time in kids, it's from previous ear tubes.
Okay.
You can also have traumatic ones. Sometimes people, fall on their ear while like water skiing or things like that, and they can pop or rupture the eardrum that way. Ear infections are a very common reason for holes in the eardrum, and then occasionally he hears some self-inflicted trauma from things like Q-tips or whatever people stick in their ears. So, so you have to be careful of those things, but that's the most common reason why we see holes in the eardrum.
Okay. All right. We've got another question. This one's from Hannah. Hannah wants to know: is it normal to have pain in your ears months after having tubes?
That's not typical. I mean, most of the time they have pain maybe right after surgery for maybe a few hours, if that. Most of the time you don't have ear pain after pressure equalization tubes. If you have a chronic ongoing infection, there's lots of inflammation in the ear, you can have pain. The strange thing about ear pain is most of the time ear pain is not from the ear. It's usually referred pain. A lot of the nerves that innervate the ear canal or give you sensation in your ear canal also can give sensation to other parts of your head and neck.
Okay.
And so one of the most common culprits is your jaw joint. Oftentimes you can have arthritis in your jaw joint, or people who grind their teeth while they're sleeping, they can have pain, and it feels like it's in the ear canal, but in fact it's arising from the jaw joint. Another common reason is they can get musculoskeletal pain, a muscle pull or something like that, or some inflammation of the attachments to the muscle to the base of the skull. Those nerves that innervate that area also innervate the ear canal. So it can be perceived as ear pain, but it's not really from the ear.
Okay.
I'd say the vast majority of the time when I see someone with ear pain, the ear looks totally fine.
Yeah,
so
it's a good question, Hannah. So with the skull-based surgery, though, I mean, what does recovery look like? I'm assuming it's a lot shorter with minimally invasive.
Well, it depends on what you're doing, but for acoustic neuroma, the most common reason why people stay in the hospital is because their balance dysfunction afterwards. You have to cut the balance nerves in order to remove the tumor.
Gotcha.
And so patients are dizzy and off balance for several days or weeks or months afterwards. So ultimately, that's what determines recovery. That being said, for the patients that we've done this approach on, where we've removed the tumor through the ear canal, for whatever reason, they are going home faster. I mean, normally a acoustic neuroma after surgery is going home at post-operative day 4 or 5, whereas our patients have gone home day 2 or 3. So, for whatever reason, they're recovering faster, even though it's a slightly different approach than we traditionally do behind the ear. Going through the ear canal, at least so far, the few patients that we've done that way have recovered faster.
That's good to know. That's really good to know. So one of the questions that came through beforehand, this was from Judith Walsh, and I'm not sure if she's watching, but she was wondering, she says, I have eustachian tube dysfunction. Are there any treatments available? Could this be an endoscopic procedure?
So yes, but different approach. So traditionally for eustachian tube dysfunction, we used to treat it conservatively with using nasal steroid sprays, but there are a number of studies that have showed that doesn't really work. And so traditional other options that are kind of non-invasive include allergy management. We have lots of allergy problems here in North Texas, and so that's a common trigger for eustachian tube dysfunction. And so getting allergy tested and treated with either immunotherapy, either sublingual therapy with drops or shots. I get shots every week for my allergies. And that can help. As far as in more kind of procedural options, the traditional thing is to place a tympanostomy tube, which is what we were talking about earlier. That's a traditional way of doing it. There was a procedure that was just approved by the FDA called balloon eustachian tuboplasty. And what that involves is using an endoscope, but going through your nose. The eustachian tube actually opens up inside in the back of your nose in your nasopharynx. And so what we can do is we can take a little wire almost, or tube that has a balloon on the end of it, and you put that up through the eustachian tube orifice in the nasopharynx, and you fill it with saline or water and leave it up there for 2 minutes. And then you deflate it and take it out. And so the whole role of that, the eustachian tube is actually closed at all times except when you swallow or yawn, and it opens and allows gas exchange between your middle ear space behind your eardrum and the outside world. And so with patients with eustachian tube dysfunction, that tube either anatomically is just very narrow and never opens, or more commonly it's a mucosal problem. Mucosa is what lines the inside of our nose and our eustachian tube, and that mucosa gets swollen, basically, for lack of a better word. And so what the eustachian tube does is it actually histologically, when you look at the eustachian tube after surgery, the cells that are causing the inflammation get crushed to some degree after the balloon procedure, and so then it scars, and then the tube is in a more natural open position afterwards. And so we have some data up to a year out with the FDA trial that showed about 70% of patients who were not able to pop their ears before surgery were able to do so afterwards. So that is a new procedure. It is endoscopic, minimally invasive, but it's through the nose, not the ear. So that's only approved now in the U.S. for patients over the age of 21.
It's not for kids.
Not for kids. You'd have to use it off-label, which is a whole different discussion. But that just got approved in November of 2016. So.
Okay, good question. We got a bunch of questions coming through here. This one's from Gina. So this one, she says, a couple years back, it felt like my ear was stopped up. They couldn't find anything wrong. They wanted to do an MRI. The problem cleared up on his own because apparently she didn't have the MRI. Regardless, she says, are there any extensive diagnostics that can be done without using an MRI? Or is that the standard?
Yeah, I guess it depends. If you're looking for, hearing loss, you can do an audiogram, which is a non-invasive study where they put a little insert in your ear and you go into a soundproof booth and they basically do some testing with kind of pure tones, and then they do speech testing as well. That can test your hearing and then how well your eardrum moves in and out. And then you can do balance testing that's relatively non-invasive. Some of them they're not non-invasive, but sometimes they're not so pleasant to go through because they can make you more dizzy. You can do a CAT scan. I know the problem with MRI when some people is some people are claustrophobic, and being in a tight space is very difficult for some people. So they have open MRIs which you can use, but sometimes a CT scan will work, and that's not in an enclosed of a space, and you can get some information for that. If you're trying to look for a tumor in the inner ear or on the balance nerve like an acoustromy, you really need the MRI. Unless it's a very large tumor, it's going to be harder to see on a CT scan. There's some other studies you can do, like auditory brainstem response, which you can do in the office. But in general, for looking for tumors and things like that, the MRI is the best study to do.
Okay. So we got a couple questions that came through. There was one from Beverly earlier and one from Sarah Connor now. She says, does this have anything about tinnitus? I think they're wondering can you fix tinnitus?
Yeah, there is right now, as of now, there's not an approved procedure for managing tinnitus. There are some, if a patient has like total loss of hearing or is essentially deaf or severe hearing loss, cochlear implant is a very good option for hearing loss, but also in about 70% of patients with hearing loss who have tinnitus, the tinnitus actually improves with a cochlear implant. And that's not an endoscopic procedure, it's a traditional behind the ear procedure. But that's an effective operation, but we don't usually do that for a strict indication of tinnitus. At least in most commercial insurers, and Medicare won't pay for that. You can do, probably the most effective thing for tinnitus that we have, or there are a number of things, you can do something called tinnitus retraining therapy, which we do offer here at UT Southwestern. There are a number of audiology practices in Dallas-Fort Worth who also offer that. And that's a program, there's no quick fix for tinnitus. There are lots of things that you can do to make it so it's not so intrusive and bothersome, but it's not like you're going to walk into the office and walk out with your tinnitus gone. But there are a number of things that can be helpful depending what your hearing status is and what you're willing to do to eliminate it. But as of now, there's not a direct surgical option for that other than an implant, which is more indirect.
Right.
So.
Okay. So we've got one from Andy, and this is related to skull-based surgery. So is smell or taste permanently affected after surgery? Does it impact those?
It can. So not for smell, for doing endoscopic ear surgery, that's generally not affected, but there is a nerve that runs through the ear called the chordotympani nerve, and that controls the taste buds on one side of your tongue.
Okay.
And so sometimes we have to remove that nerve for, various disease processes like cholesteatoma. If it wraps around that nerve because it's right underneath the eardrum, you have to remove it. And so you can have a permanent altered sense of taste on your tongue. Some patients describe it as a bitter or metallic taste sometimes. And that usually, over time, most patients, they get used to it and it's not so intrusive.
Okay.
As far as smell, doing endoscopic ear surgery, that shouldn't be affected by the surgery.
Okay.
Certainly if you're doing endoscopic sinus surgery, it can definitely be affected by that. And taking out tumors through the base of the skull can be affected by that, or can cause smell loss or smell taste or smell changes.
Something like that. Well, good question, Andy. I'm going to take a minute just to thank everybody who's joined us. We've got about 15 minutes left, so keep those questions coming. In the meantime, we've got one from Michelle. Michelle says, how long does vertigo from labyrinthitis usually last?
Good question. So labyrinthitis typically another name for it is vestibular neuritis. Labyrinthitis, we usually call it that if you have a hearing loss associated with dizziness. If you just have the dizziness, it's usually called vestibular neuritis. And what that reflects is we think it's inflammation of the hearing nerve, or just the isolated portion of the inner ear, which is this right here. There you have your cochlea, which is your hearing organ, and then you have the vestibular system, which are these balance canals and the otolith organs underneath this little bone here. And so normally labyrinthitis or vestibular neuritis, you have severe vertigo for the first 24 to 48 hours. And then usually after that, the severe vertigo is gone, but you can have prolonged imbalance and movement-associated dizziness for anywhere from a few days to months or sometimes permanently in some patients. But normally, if you do something called vestibular rehab, which is usually offered by a physical therapist with expertise in balance disorders, most patients can overcome that, provided they don't have other problems. So if you've had a stroke or something like that, then your brain's ability to compensate from those injuries are more challenging.
Got you. Okay, and that addresses Nina, who just asked about vertigo.
Yeah.
Same type of thing. All right, let's see. We've got one from Judith. She says, thank you for the information about eustachian tube dysfunction. Who should I see at your clinic for my issue?
So you can see we have a number of providers, myself, and I have a few partners, and we have some other otolaryngologists who see patients for eustachian tube dysfunction. A lot of times we typically start with some more conservative therapies first. We don't try to go straight to surgery because sometimes there are things that are less invasive and maybe less risky than doing a balloon procedure, although that's not that high risk. That may be effective and actually treats the underlying problem. So we have a number of providers in our clinic that can address our concerns.
Okay, so we will be sure to share the make an appointment or request an appointment page in our feed so you can call or request an appointment online.
Great.
Perfect. So we've got one from Crystal that came through earlier. She says, are skull-based tumors or growths genetic?
So they can be, yes. Not most tumors that we see, especially for acoustic neuroma, maybe about 5% of them are genetic. And that's a condition called Neurofibromatosis 2, which I think Dr. Coots had talked about a few weeks ago.
A little bit.
And so most of our acoustic neuromas are sporadic, which means there's no family history, and they have a tumor just in one ear, not the other ear. But again, a rare population of patients, you'll see that it can be genetic. There's another tumor that we see with a little less frequency called a paraganglioma or a glomus tumor. It's a vascular tumor that looks like a red mass behind the eardrum. And so those can be hereditary too, and that's probably more frequently hereditary. And we send all of our patients for genetic testing for that when we see them. So that can help with that. And that's important for that patient because sometimes some of these genetic conditions can predispose you to getting multiple tumors. And it also has implications for your family members. So if your parents, your siblings, or if you have any kids, there's always a possibility that they could have the same condition. And if you monitor and screen those patients earlier if they had the gene, then you can pick the tumors up early and treat them when they're more manageable. So.
Gotcha. Okay. So I'm assuming there are some risks to skull-based surgery.
Yes.
Can we talk a little bit about those?
Yeah, sure. So at least through the ear or any skull-based surgery, especially what's called lateral skull-based, which has to do with the temporal bone, which is anything kind of on the side of your head. Risks include your facial nerve. That's the nerve that moves your face. That can always get injured, and you can have a weak face like a Bell's palsy. And a lot of times that's temporary, but occasionally it can be permanent.
Dr. Coots mentioned that last time.
Hearing loss is certainly one of the more common presenting symptoms of skull-base tumors.
Okay.
Sometimes we can save the hearing, and a lot of times it's already been lost at the before the patient's had surgery.
Gotcha.
But certainly we can be responsible for the hearing loss in certain situations. If you have a very large tumor, then saving the hearing is not always an easy way to do things. For this minimally invasive approach to acoustic aromas, those are only in patients who have no hearing left, basically. And the reason for that is because we have to drill through the cochlea, which is the hearing part of your inner ear. You have to drill through that to get to the tumor, basically. So we're only doing that on patients who have no hearing left, basically.
Okay.
So other risks are you can be dizzy after the surgery, especially if the tumor involves the hearing and balance system, either the nerve or the inner ear. You can get a spinal fluid leak. That's the clear fluid that surrounds your brain. We're opening that spinal fluid space up to get the tumor out. And so it can either leak out through the incision or out your nose, because your ear is connected to your nose through the eustachian tube.
Right.
And then there's always a rare chance of meningitis or having a stroke or not making it through the surgery. Fortunately, those things are really rare, but we have to mention them, and we discuss that with all our patients before we take them to the operating room.
Okay, so those are the pitfalls, or those are the risks.
Right.
Obviously, the benefits. Can it restore hearing?
So with skull-base surgery, it depends. A lot of times, again, the hearing's already been damaged, and there's not a simple way to restore it. In some patients, you can place a cochlear implant to restore sound perception in that ear in some cases. And there's some patients who have this neurofibromatosis too, who have deafness in both ears, and maybe one of the tumors is small. You can actually put a cochlear implant in that patient, and they can get a decent response from that and restore some sound perception, maybe enough to where they can be as close to as functional as they were before, but it takes some time to get used to the implant.
Right.
But then sometimes, usually if you have a skull-base disorder, you can't really restore hearing often. Our goal would be to preserve it at the current level that it's at. As far as middle ear problems like eardrum perforations and cholesteatoma, or if you're missing the ear bones, or if you have something called otosclerosis, you can definitely restore hearing with that type of surgery. And so what we do is we lift up the eardrum, and then we basically repair. There are three little ear bones. There's the malleus, which is this right here, the incus, which is this right here. It's not a great replica, but it's not bad. And you can actually, if those bones are missing or partially eroded by the cholesteatoma or chronic infection, you can actually replace it with an implant. Or sometimes you can even take them out and carve them and sculpt them and put it back in at a different place to restore hearing.
Wow.
And they're really small. This is much larger than a typical ear bone. The ear bones are only several millimeters in size. So having an endoscope or a microscope magnifies those so you can see them much easier and work with them much easier. So.
Absolutely. Wow, that's amazing. So we've got a question from Gina. She says, are there any ear problems that can be caused by autoimmune issues?
Yeah, absolutely. So there's something called autoimmune inner ear disease, and it's more common in patients who have autoimmune conditions like lupus or rheumatoid arthritis or Sjogren's. And so it typically presents with a relatively rapidly progressive hearing loss, and usually it's an inner ear related hearing loss, so cochlear or hearing nerve. And so we used to think that the inner ear was an immunologically privileged site, which means the immune system really wasn't active in the inner ear.
Right.
That's not true. And so patients who have autoimmune diseases, and sometimes even if they don't, can have an immune response to their inner ear and have their hearing kind of decline to the point where they're deaf. And typical treatment for that is using high-dose steroids for about a month with a 2-week tapering off of the steroids, and that can be effective in a lot of patients. Sometimes that doesn't work, and you have to use stronger immunomodulating agents, which you would use for like lupus or some of these other autoimmune conditions, and that can sometimes, at least stabilize the hearing. And in some patients, there's nothing really that can work to save their hearing, and so in those patients, a cochlear implant actually works really well for those patients, provided they haven't been deaf for a long time. So most of the time they're pretty anxious about their hearing, and they come in right away because their hearing is rapidly declining. And so, not a very common condition, but being a referral center, we see a fair amount of autoimmune inner ear disease, and we manage it with medications at first, and we have a really good working relationship with our rheumatologist who helps us manage those patients and take care of them. And actually, there is an ongoing study with that as well. So.
Okay. So what you mentioned, that people usually come in when they first notice their hearing loss. What are other symptoms that people shouldn't ignore when it comes to their hearing?
Great question. So if you have a ear that's chronically draining, basically, and it smells bad, it's yellow-green drainage, that's not normal.
Yeah.
So if you've had that going on for a long period of time, or even if it goes away and comes back, like you put some drops in there, or you take an antibiotic, goes away, but it comes back a few months later, that's pretty much a hallmark for cholesteatoma, which we discussed earlier. So ear pain is not that commonly associated with ear infections, but if you have that drainage like that and you have ear pain, that's really you need to get in, because sometimes you can develop intracranial infections like meningitis or a brain abscess from ear infections. It used to be the most common reason why people were hospitalized with infectious diseases back before we had antibiotics.
Wow.
Now it's not as common, but so if you have a draining ear that's all the time, then that needs to be evaluated. Certainly, if you have progressive hearing loss in one ear and the other ear is normal, you need to have that evaluated.
Okay.
And that can be inner ear or middle. It can be a number of different problems. So certainly, if you have vertigo can sometimes be a harbinger of bad ear disease. If you're like straining or sneezing or coughing and you're getting dizzy every time you do that, and you have draining out of your ear, you need to come in. So those are some things to look out for, basically.
Yeah.
And certainly, obviously hearing loss is an obvious one, which we just discussed. So.
We did. I didn't realize about the draining part.
Yeah.
That's interesting. So while we were talking about that, we had another question come in. She says, if you have a skull-based tumor, how long does it take for symptoms to appear?
Good question. That's totally variable. So we have patients who've come in with enormous tumors and had virtually no symptoms, and they were instantly discovered because they were getting an MRI for some other like neck problem. Then we have patients who have tiny tumors who have total loss of hearing. So it kind of runs the whole full spectrum basically.
Okay.
So, but most common symptom of an acoustic neuroma, which is one of the more common skull-based tumors we see, is hearing loss. About 70% of patients will have some vestibular symptoms. A lot of patients will have tinnitus. And usually all those symptoms are usually localized to one side. So a lot of people, tinnitus in both ears is very common. And so most people with tinnitus do not have tumors.
Okay.
It's more of a brain processing issue with sound relative to your sound perception. But if you have symptoms only on one side, that's something you probably should get looked at.
Okay, that's a good question. We've got one from Lori. So Lori Freer, she says, my elderly mother was rear-ended in her car. She lost some of her hearing and taste. Do you think that will improve over time?
Maybe.
There could be other factors.
So other factors, they probably need to have it evaluated and get a hearing test and see a specialist, and we can certainly evaluate in our clinic for that, or if they don't live far away or remotely, we can give them some recommendations for who to see for that. But it'd be worthwhile getting a hearing test. You can get something called a temporal bone fracture. So like any trauma, your temporal bone actually is one of the hardest bones in your body, but it can break too.
Okay.
And so sometimes it breaks through the eardrum or through the ear bones, and you can get hearing loss from that. And that taste nerve, which runs through the ear bones, actually gets stretched or injured, and you can have an altered sense of taste.
So it's possible if you're in a car accident, like this individual, Lori's mother was, that she could have damaged that bone?
Yeah, possibly. If she hit her head hard enough, certainly.
Oh.
And even just sometimes mild head trauma can cause loss of smell, which is perceived as loss of taste as well. So that could be another mechanism.
Okay. Wow. All right. Let me see. We had one other question that came in that I missed earlier. This one was from Andy, and we've got about 2 minutes left. So if you've got your questions, put it in really quickly. But Andy was wondering, could a skull-based tumor be found on the spinal cord, the upper part?
So yeah, so there's the brain stem kind of comes out right at the base of the skull. It doesn't show in here, and so the spinal cord attaches there. So there are some tumors that show up right there.
Okay.
Usually more common tumors are meningiomas, and we have an excellent neurosurgery program here with Doctors Barnett and Mickey and Toral Patel, and an excellent spine center here that can address those things. Normally, you can't address those things through the ear, but you can certainly get skull-based pathology there, and we have a multidisciplinary skull-based center that can address that.
Okay, awesome. Let me see. I think we are running out of time. So I know one of the things you wanted to talk about before we go was you want to talk about the clinical trials that are underway here.
So
at
yeah,
Southwestern.
we have one that we mentioned about the pain study. Basically, any patient who's having ear surgery, we offer them enrollment in this study, and all they do is have to track their pain afterwards. It doesn't affect how we're managing them.
Yep.
We just ask them that we give them a handout of how to follow their pain symptoms, basically, or follow the pain symptoms for 7 days after surgery, and we're going to eventually publish the results of that. So
And what are you trying to find with that?
we're trying to see if endoscopic ear surgery is less painful than traditional surgery. We would assume that it is because we're not making a big incision behind the ear, but we don't really know that for sure. So we're trying to look at that.
Okay, that sounds fascinating. So anyway, we're gonna wrap up today. It's been a wonderful chat. Thank you for all of your questions and for participating. Thank you for joining us.
Thanks for having me. I've enjoyed it.
Absolutely, yeah. And so we will be back probably in a couple weeks. So stay tuned for future topics. In the meantime, thank you for joining us.